So I will start now. Big welcome to everybody. It's nice to have you all here, the speakers as well that you're supporting us, and the audience as well. And some of you may already know KnowEMS, the project, have been here plenty of times. Others may be new. So the reason is now I want to just tell you very, very quick and don't waste any time what KnowEMS is and what it's about and where it comes from. So KnowEMS is not just one organization. We have plenty there. We have the colleagues from France, SFMC, APHP. We have the colleagues from Spain, SAMOPC. We have colleagues from Portugal, ENM, colleagues from Israel, Magen David Adom, and colleagues from Romania, DSU, and colleagues from Germany, the UNITA. And the context and the background of this whole project is another project which was called No Fear. The full name is Network of Practitioners for Emergency and Medical Systems. And its goal was to improve collaboration and share best practices and support innovation in emergency medical services and critical care through workshops, webinars, joint exercises. And the project helped to strengthen Europe's preparedness and response to crises like COVID-19. So they've indicated priorities for standardization, support quick wins and practical short-term results, and implemented a transactional dynamic portal providing fora, a catalog, and a place and for flexibility to address new threats. And what are we doing now? We do monthly webinars, especially we do 2 webinars each month now. And the first one is always held on the first Thursday of every month. And the other one is 2 weeks later on a Thursday. And the past topics have been, for example, EMS organizations and the Madrid metro bombing, management of burns and mass incidents, emergency services, and mass gathering events. And if you missed one of our webinars, they are all recorded. So check out our YouTube channel. You can find every recording there if there's an interesting topic for you. And as we are on a hunt for interesting topics, we are always looking for some. Please scan this QR code and give us new ideas if you know a topic you want to talk about, you want to hear about, and you want to be discussed. And if you're not already a part of our KnowEMS network to don't miss anything, please scan this QR code. I will post it in the chat as well afterwards, and then become a part. Don't miss anything to be informed about every interesting topic and webinar we are planning. Thank you. Back to you, Chaim.
Thank you. Thank you for joining us. We have today a very interesting topic, which is implementing changes in EMS. I would say that this is something that comes with us from the times of COVID. And I'm sure that some of you were with us in EMS services during COVID. And you remember those wonderful days where protocols changed every day. Today, we are intubating the patients with COVID. Tomorrow, we are not. 3 days later, it is a maybe. And every morning we woke up and the first question was our medical director, Dr. Strugo, what have you changed overnight? Normal days are not like that, but we still have to make changes. Just to give you an example, I'm from Magen David Adom in Israel. We are a paramedic-based organization with 2,500 staff members and around 1,000 paramedics on the field with 30,000 volunteers. So every time someone just throws to the air the word change, we have something and we need to change it. That implies 35,000 people that have to be retrained, readjusted, whatever name you have, to the new ideas that we are bringing to the field. And this is the challenge that we are going to discuss today with some brilliant ideas from our speakers. Thank you for being with us. understanding that unlike we used to think 20 years ago, sending a memo and saying, okay, I send the memo, it's done, is not the implementation of a change. So we want to see how we are doing it with success stories. So I would hand over to my speakers, and I would kindly ask them to introduce themselves and the organization, because I hate reading from papers, bios of others. So Amy, over to you. Thank you very much.
Thanks a lot, Chairman, and I'm happy to be here and happy to contribute to the conversation. I'm conscious that I've only got 10 minutes, but I'm going to introduce myself quickly. So I'm Amy Iguanu, and I work for the Southeast Coast Ambulance Service as Head of Quality Improvement and also interim Head of PMO, so Program Management Office. So quite busy. And, you know, we've only had quality improvement methodology in the organization for over 2 or 3 years now. Well, actually coming up to 2 years. So I'm going to share some slides if that's okay, and I'll give you a little bit of a context around the organization, but I recognize that, you know, there's quite a lot to cover in a short time. So I'm very happy to also take questions at the end of this. So bear with me and I will share my slides.
They're not in, yeah.
Can you see that? Yes. Okay. So very quickly, so like I said, I work for Southeast Coast Ambulance Service, so very busy provider of ambulance services. And you can kind of see some of the calls. I've only given information over the 22-23 financial year because I put this quite quickly together. But we provide urgent and emergency care to over 5 million people across 3,700. You can see the numbers on the 3,670 miles, which kind of represents 9% of England's population across 7% of the land area that you can see on there. And just in terms of the networks that we have within our geographical areas, so we operate within what we call 4 integrated care systems. We, you know, link in with 4 trauma networks, 3 integrated stroke delivery networks. And, you know, we're quite a busy provider because we provide services to 11 acute hospitals across 18 hospital sites, 10 community providers, and we work alongside, you know, fire and rescue services, 3 police forces. So you can see, you know, all of those services that we kind of linking with to provide that integrated care for our patients. Okay. And these are kind of the areas. So I've said already, so we employ over 5,000 staff who work across 115 sites in 3 regions in the Southeast. And our patients range from the critically ill and injured who need specialist treatment to those who need minor healthcare needs, okay, who are kind of very much focused in terms of getting help from the community. And in addition to 999 services or ambulance response services, we also provide 111 services across all of those regions. So in terms of quality improvement then, so like I said, are part of a small quality improvement team, and quality improvement is obviously one of the approaches to change management. It's not the only approach, but quality improvement is really important for us in the organization, and we kind of started our journey in 2022. And for me, if you ask me, quality improvement, we say, is not a silver bullet, but it's absolutely crucial in terms of engaging with staff, utilizing data to drive decision making before you even talk about implementing changes or improvement. Okay, so our quality improvement approach, I don't know if a lot of people have heard about this on the call, but we utilize a 6 Sigma methodology. And the main framework within 6 Sigma methodology is what is defined as DMAIC, or called DMAIC. And DMAIC stands for defining the problem, measurement, analyze, improve, and control. And essentially, sometimes people say, you know, in terms of when we get feedback from our stakeholders, people say this takes a lot of time. But for me, we always say nobody gets kudos for solving a problem that doesn't exist. And many times, you know, back to what you were saying there, Chaim, that, you know, there's such a pressure to come up with solutions. But what we don't want to do is come up with sticky plaster approaches to problems. And so the DMAIC framework helps you to really understand the problem you're trying to solve, utilize data to enable you get to the root causes of those issues before you even begin to identify improvement. And even when you get to the improvement phase, you've got to test those solutions on a small scale, because if you're able to test them on a small scale and identify learnings from that, when you then roll it out wider, you're able to then be more successful with your improvements. And then the control phase is really about making sure that those improvements are sustainable and that you can monitor them on an ongoing basis. So that's the kind of framework that we use for quality improvement within the organization. And it's been around for a long time. So like I said, some of you might recognize it on the call because it's being utilized. You know, it came from Toyota within the manufacturing space, but these days it's being used massively in healthcare and other approaches, you know, across Amazon, Firefox, and other organizations in the private sector. Okay, so when we launched our strategy, then we identified a number of metrics that will help us recognize very quickly if we were succeeding in rolling out our quality improvement approach or continuous improvement approach. And so I'm not going to go through all of this detail, but one of the things we wanted to focus on was capacity and capability building, because if you're talking about quality improvement approaches, people don't even know what it is. When you say to somebody, what is quality improvement? They tell you it's improving quality, and it's not that. It's part of that, but quality improvement is much more than just improving quality. It's about getting all of the stakeholders around the table who are closest to the issue. It's really using data to understand what the problems are, and then it's rolling out improvements on a small scale till you get to sustainable improvement. So we had to focus a lot of our time on training in the first 6 months, and we gave ourselves a target of training up to 1,000 people across the organization. And to date, we've trained nearly 1,500, which I think for a small team of 3 people, I think that's a massive success. We also wanted to focus on our middle managers in the organization, because if you can get your middle managers on board with what you're trying to do, then it means it can get down to all levels of the organization quite quickly, because sometimes that's where the bottleneck is. And so we know that training is not enough. So we had to also focus our methodology on what we call complex adaptive problems across the organization. Okay. So on one hand, we're training people how to, you know, training them about what quality improvement is about. But on the other hand, we're showing them in practice how to utilize quality improvement methodology to address real issues within the organization and at pace. So, one of the first projects then that we then set out to deliver was that we found out from a quality summit we had done with our stakeholders within the region that our biggest risk as an organization was held within our waiting list, or our callback list, if you like. So essentially, when our patients call the service, if they are not able to get through to a clinician the first time, then they're put on a waiting list, and for the clinician to call them back. What we found was that whilst they're waiting, potentially they were deteriorating, and we know that any kind of waiting is bad for patient outcomes, right? Any delays at all to clinicians seeing a patient, whether it's within an acute setting, whether it's within an ambulance service setting, any setting, it's not good for patient outcomes. So the task was, how do we reduce harm to patients who are waiting a clinical call back in our queue? And what we did first was then to quickly look at the data, try to find out where the biggest harm was happening to our patients. Now, one of the limitations we have as a service is that we do not have data that shows us the full end-to-end patient journey. So, for example, when a patient phones our service and we offer them a diagnosis and an outcome, if they are referred on to an acute hospital, for example, we don't really get any information back from the acute hospital or the community hospitals about what has happened to that patient. So we can't really say which of our patients have come to harm because of the delays within our service. So we decided to look at this in a very different way. And what we found out, and I'll give you one example. First of all, we found out that we had high volumes of duplicate calls into the service. Around 26% of our calls were, down to duplicate calls. And essentially, that meant that when patients called us, because we were delaying in coming back to them with an outcome, they were then calling us back again to follow up the call. And that was generating a lot of activity, which shouldn't really be, generated in the first place. So again, that was something that we know we needed to deal with. So one more thing I'm going to say before I move on then. So we quickly found out then that our clinicians were spending a lot of time. So we had to look at the project in a different way and cut the data in a different way. We found out that our clinicians were spending a lot of time closing down duplicate calls, right? And what we said is, I don't know any clinician who's, become a clinician, completed the clinical training, who says, oh, I went into the service because I want to close down duplicate calls. So closing down duplicate calls is non-value added activity, and we found out that our clinicians were spending a lot of time on closing down duplicate calls. Clinicians were also spending a lot of time on welfare calling. So they were having to call a lot of patients to say, we haven't forgotten about you, we'll get back to you as soon as possible. And we also obviously recognize quite quickly that that's not a good use of clinician time. So a lot of manual things were happening behind the scenes, and we know that if we take away some of these tasks from our clinicians or automate the process, it means that they have more time to focus on patients who are critically unwell and need help first time round. So what did we do? And I'm compressing all of this into a small amount of time. On the 17th of July in 2024, we moved to automation of sending welfare texts to patients who are awaiting an ambulance response. So instead of a clinician calling them to say, we haven't forgotten about you and we'll soon be with you, we started sending out automated text messages, utilizing the amount of time, depending on the priority of the call or the category of the call. And also what we then rolled out was, once that message gets to the patient then has an opportunity to actually cancel the call if they no longer want to speak to a clinician. And at the time we rolled out this improvement, we had sent out, well, by January 2025, we had sent out nearly 400,000 text messages, and we saw that 4,000 clinical hours were saved during this period. So think about that, 4,000 clinical hours that can be put back into actually caring for patients directly. And, as part of the quality improvement team, we supported, operational colleagues to manage this project to the point where we started delivering some of these improvements. And we've now closed down that project from a quality improvement perspective and handed it back to our EOC colleagues to carry on with these improvements. But that automation of text messages had made such a massive difference, and has released clinical hours, but also non-clinical hours, because when a patient first calls the service, they speak to an EMA, and some of those duplicate calls, now the EMAs don't have to take that, and they're now using that time to actually speak to patients who need help urgently. So I think I've run out of time in terms of just talking about all of the work that we're doing, but there are lots of other projects that we're doing, local projects, and lots of really good work, even at the local level, not just at a strategic level. So I'm just going to stop there and take any questions. I hope that's been helpful.
Amy, thank you so much. You deserve some water. Or tea. We will have the questions at the end, and I have to say that I'm amazed by your text program. I hope it didn't die when you handed it over back. I think this is one of the greatest challenges, but this is the kind of solutions that I would say you would never think about an automated tool to solve what you perceive as a clinical issue, but it looks like you found a very innovative and amazing way of really focusing your clinical people on the real work and not just texting, especially that, at least myself, I still type with one finger. So closing a call will take me a considerable amount of time. Thank you so much. As I said, please put your questions in the Q&A and we will address them at the end. Israel, on behalf of Samur, please.
Hello. Thank you for inviting me. I'm Israel Garcia, EMT with Samur Civil Protection. I am in hospital, pre-hospital care. Well, we see that we have a problem about the spider straps. I start to share my screen. Okay. Can you see it right? Okay, right?
Yeah.
It's fine? Okay.
Yeah.
Well, let me check because I lose it. Okay. Well, to begin, I would like to highlight the advantages of the spider strap device before addressing the various issues identified in the original system brought to us. With our service, I had to redesign in order to meet different operational needs. The first and foremost device, this device enables to evacuate patient in fully vertical position, as you can see in this picture. So we can evacuate a patient in elevators, on remote areas, or even in stairways where horizontal maneuvering is not feasible. So I think this is the most versatile thing to do with this one. The advances, in rare case, the patient may even be positioned laterally. In my opinion, this is the most appropriate when the patient is at risk of vomiting or in extremely narrow spaces where even a single person barely fits. I use it in my personal field, and I think that, well, I like it. The color code design of the straps facilitates the teamwork, allowing for a quicker and more accurate placement while minimizing the risk of error. The main characteristics, the straps are adjustable in length and height to immobilize of different size, reduce of patient movement during pre-hospital handling, and we can secure the patient into a spine board or scoop stretcher. So among these key features, nothing that this is a robust system, easy to apply even by personnel with minimal training. We usually collaborate with police officers or firefighters in our interventions. So at the end of the presentation, I try to explain how to place it in about 2 slides. So we can use this one even in the hospital area because we can use, we can keep them for CT scan or X-ray without needing to remove it. The problem that we find, or the workers report us, is doesn't fit the needs of patients with very low volume, as you can see in the next slides. It doesn't meet the needs of patients with low height. It doesn't fit the needs of patients with a lot of height and volume. Because I see that it have enough hook and loop fasteners on the strap that use different body types. So it's make to keep loose, as you can see in the third picture, and is not high adjustment, always keep on the mid-seam area of the legs and keep the foot insecure. For this reason, we have to redesign this device with the same colors, with the same adjustment, but we got a more area with hook and loops, so we can fasten each other. So we can secure the patient into the spinal board or scoop stretcher. We place the SAMUR logo because we do that with every item that we have, but we keep the color code. The transverse strap includes the length of the transverse, so we use on obese patients higher percent of Velcro or hook and loops lengths. The insertion position fixed shoulder has been modified to make the patient more comfortable with them. An additional length adjustment point because the one that we have on our service only have one adjustment point, and now we have 3 adjustment points for chest and legs. Okay, and now we are going to explain how to place it. Sorry if I go a little fast with this presentation, but first of all we need to place the device in the scoop stretcher to have a clear reference how positioning. This is very important for people even with no knowledge about how to place it because it's simple. You just need to keep the minimal movement for our patients. So when we have the patient over the scoop stretcher, we'll place the spider from head to toe. Through all this process, we need to keep calm and we need to talk with our patient because usually we don't do that. We always try to do anything automatically and patients are always asking, what are we doing? Where are we going? If it's going to hurt me or something, and we need to reassure them. Finally, we'll have the patient securing the scoop stretcher. As you can see, in this case, we don't have the head immobilizer placed. Just to see that with our modification, the chest straps can be placed. But I like, and this is something that I like to explain because we always place them ready in the handle of the top when we have another hole between the top and the middle one, that is where the spider strap, we need to place them. And usually we don't do that. So the head immobilizer always had to be placed not so well. And when we try to evacuate the patient in elevators or through the stairs, it always loses the head immobilizer. So I know it's a very short, but I think that we only have 5 minutes about it. So if anyone have any question, we can solve it at the end.
Israel, thank you very much. Very interesting. I have to say that I'm amazed by the idea that a service has a real impact on the market.
Yeah.
Because I think the main point from my side is that normally we sit in our ready room and, sorry for my French, we bitch about the equipment, bringing a lot of complaints why it's not fit for purpose, and it stays like that. And that's the first time I see that you go back to the vendors and say, guys, you need to do some changes so it will fit what we need. And I think that this is a model that we should all learn from. So congratulations on that. Oh,
thank you.
Enhorabuena.
Thank you.
I will hand over to Tomer from Magenta Vita. Tomer, please.
Hi again, everyone. My name is Tomer. I'm the
Tomer, your
head.
camera is off.
My camera is not off. Guy, can you see me?
No?
Yeah.
But go ahead.
No.
No?
No, but we can hear you.
Now?
Tomer,
Well, I
it's
can
not-
see myself.
Okay, we
hi.
don't see you, but never mind.
Okay.
Later we'll send a picture of your beautiful face.
Exactly. Okay, so I'm the head of the QA Patient Safety Department in MDA, part of the medical division. As Chaim said at the beginning, we have many implementation challenges in such a large-scale organization. We decided to focus this time on a specific issue, which was introduction of a new ventilator, transport ventilator, into the organization, something we started back in 2022 ish. And what we did, as Chaim said, there's many challenges. And first of all, training, we went and trained all the paramedics within the organizations. We recorded special videos on how to use the ventilators in special settings with all the equipment. We introduced the ventilator into our online protocols. I'm going to share it now so you can see how it looks. Just let me know if you can see it. Chaim, can you see it? No?
No.
Okay, I guess something went wrong with the Teams. Never mind. So we introduced it into our online protocols, which are also available on the team app. So actually every team member on his phone can access the protocols. It's an online version. Everything is hyperlinked, so you can access the movies and all the reference to the equipment or medicines you use. And after doing all of the above, we still had issues on how to train the paramedics on using the ventilators on certain patients or on certain situation when transferring a patient and the situation changes. Since it's a very smart ventilator, we addressed the company, and the company said, all right, we're going to go with you and try to find a solution in order to make it easier to train our paramedics on those situations, because it's something you can't simulate, not on a doll or even hard to train even when using the ventilators, because you can't simulate a patient. And that's why we also invited Guy. He's a representative of the company, and he's going to show you the company side of the implementation. So Guy, the floor is yours. Guy?
Hi, can you hear me?
Yes.
Yeah, we can
Wonderful.
hear you.
So wonderful. So thank you, Tomer. It's a pleasure to be here. So for us, my name is first of all, my name is Guy Hoffman. I'm the Chief Product Officer for Innovative Medical Solutions. We are the manufacturer of the ventilator Sparrow. And as Tomer mentioned, I want to talk to you about how we move from a protocol and practice and how to implement the ventilator training into the EMS surroundings and how to train the personnel in order to use the device in the most efficient way. Now, I'm going to give you just a minute about the ventilator so you'll have the context. And the Ventway is a very, very small, portable, lightweight ventilator. It's a turbine-based ventilator. It requires really minimum maintenance. It's very easy to operate and provides you with high performance. It's FDA and MDR approved. And even after we said all that, it is still new ventilator for the U.S. Army. I'm sorry, someone switched the screen. I just lost my my screen.
You have to reshare your screen, please.
I'll do it again. I'll do it again. Okay, so in addition to our collaboration with Magen David Adom, we're also working with the
Guy,
U.S. Army.
just one thing. Okay, now we are on
Yeah,
your
you
second
got it?
slide. Yeah.
Wonderful, wonderful. So we're also working with the U.S. Army, with several organizations in Europe as well, the Swedish Army as well, the Norwegian Air Ambulance, and in Finland we're working with several EMS organizations also. And the same things that we're seeing with Magen David Adom, we're seeing all over the world. The milestones that we have here with Magen David Adom, we started in 2021, as Tomo mentioned. We have 500 devices right now deployed in the field with thousands of paramedics that have been trained on the use of the device. Magen David Adom reported more than 2,000 cases only in 2024. And again, that goes to the level of training that Magen David Adom is able to offer. But it is our job to now enable anyone in the organization to have also the ability to train on the device, regardless if he has the device with him or not. And good. And the logistical complexity here. Yeah, can you see the screen?
I'm still on your slide with on slide number 3. If you switch slides.
I switched. Yeah. Let's see
I'm
again.
on 5, Chaim.
Me too.
Okay, so it's just mine. Please go
Oh,
ahead.
you're good. You're good. You're good. So there are a lot of logistical complexities to introduce a new ventilator and a new technology to any EMS organization, more specifically to an organization like Magen David Adom, which is a very, very big organization. And it's really not just about the logistics. It's more of a behavioral change. Several difficulties that come to mind are uneven clinical experience and protocol familiarities, high personal turnover, and shift variability, resistance to adopting new workflows, obviously fear of errors during the early use, and limited time for structured retraining, meaning with a ventilator, you'll use it, but it's not something that you'll use on a day-to-day basis. And even if you're using it once a month, you need to do retraining. And with the Ventway, even if it's it's a very simple to operate device, with us, the only thing that you need to do is 2 hours of training and you have full operational competency. But still, we wanted to provide our users, and based on Tomel's approach, we wanted to provide them Magen David Adom with an application that will allow anyone to use the device, even if they don't have it with them. So the goal is having a universal on-demand ventilator training application to enable every user to train anytime, anywhere without the need to access the physical device. And the first thing that we've done is to look at what not to do. So obviously, everyone is working with the standard classes. You'll read about it, you'll hear it from your lectures, but still, it's not enough. And having the videos, animated videos, also is not enough. And then obviously going to the other side of the spectrum, having a very, very difficult to handle, let's say like VR application, is also not something we wanted to pursue. So we designed a digital training tool, a realistic simulation of the device behavior across clinical scenarios, interactions, and giving you the ability to really perform with the device. The application will give you 360-degree view of the device and all its consumables. It will give you a quick access to all the parameters, all the features of the device, and will be able to emulate and simulate scenarios in the palm of your hands. And this is how it looks like. It's an interactive training application. Will give you the ability to explore all the different features, all the different parameters, navigate through the different screens of the device, practice, which I think is the most important part. Practice and practice and practice. And also in addition to that, you have the resources like Tomer mentioned. Second. So when you see the comparison, you have here on the right the Ventway screen. This is how the user will actually see the simulation screen is looking. You have it on your phone, on your tablet, and you're able to play with the device anywhere, anytime, without the need to having the device with you. Very, very simple to operate, very, very simple to handle, and provides you with just practice opportunities. We also provide you, obviously, with assistance and simulation scenarios, after which organizations and chief organizations are able also to look at the simulation summary and view what their users are doing, where they did something wrong, and then suggest a new protocol for them to use the device. And you're able to really navigate throughout the device itself. Here you can see in the info screen, basically we're giving you a scenario, and then we're able to provide you with a full summary of what went wrong. So every user is able to simulate a scenario and then see what happened, see his response time, see if he changed the parameters according to the summary that he has. And for us, we wanted to go beyond the training, just to build an operation and a system for resilience, giving the EMS network the ability to standardize onboarding, harmonize deployment protocols, and ensure consistent performance across all the provider levels. Hopefully, we'll be able to reach out to other organizations, but this is a project that was heavily influenced by Magen David Adom, who approached us. So thank you for that as well, Tomer.
Guy, first of all, thank you for your work on behalf of Magen David Adom, but I would like to ask you if, top of your mind, maybe yourself or Tomer, you remember what was the most common problem that people have encountered in their training?
Tomer, you want to start or should I?
Yeah, I can start. I hope my camera works now. I can see myself still. First of all, it's the fear of new changes. It's something that we always see within introducing any new equipment to the organization. So it takes time for people to get used to the equipment, to the new equipment, and know how to work it. It's hard, very hard to train on medical devices, as I said before, because it's something that part of the operating the device is the patient. So and the patient responds to the device, especially on ventilators. And the last thing is that paramedics and medics, but especially paramedics, because they're the one that uses the ventilators, are used to using the bag mask ambu bag. And there is a main difference, which is the ambu doesn't beep. So I always say in my training that if the bag mask would beep, we will hear alarms all over the country. But the ventilator is a very protective measure, but it beeps whenever you reach the limits. So it's something that they need to get used to working in those environments of digital devices.
And I think from our side, also something that we're hearing all the time is, again, how you do the change, that leap from a BVM to a mechanical ventilator, even a simple one. Still, it's a new approach, and for them, it's something that you need just to practice and practice and practice. I think that goes also to any new device that you implement. But if it's a big leap, and if you're talking about a large scale organization like Magen David Adom, then practice and just standardize.
Thank you. So we spoke about patient care, we spoke about two different devices, and now we'll go to a very different thing. Andre, please.
Hello, everyone. My name is Andy from Berlin Fire Department. I'm the acting head of the EMS planning division, and I would like to share with you some thoughts about changing response times. So I'll try if sharing works. Oh, yes, a problem, obviously. I hope this will work. No, you can't see it. Am I able to share? I'll try it another way. So you can see it?
Now we can see it, but you need please to switch to
to presentation mode.
Cool.
I hope it works. Wonderful. Okay.
Very well. Thank you.
So we had the task to implement a new dispatch logic, but the first short advert block. So EMS in Berlin is primarily operated by the Berlin Fire Department, and we are doing the EMS service. Patient transport is done by private companies, and the head of the medical director is in charge of all this. So we are serving about 3.8 million inhabitants, and we have 5,500 employees and about 500,000 calls per year, which 90% of them is EMS. So what was the task? We had a situation that we had a constantly rising demand in EMS. That's something probably everybody knows. And we had political decision that we had to respond to every call in 10 minutes. Since we know that not every patient needs a 10-minute response time, we thought how to change the system and make different response times and different medical teams depending on the medical need. But there's some slight problems because once people are used to have an ambulance in 10 minutes, they are expecting it to come. The politicians have the fear if we change something that we will kill someone, and the staff also has to be informed what we are doing. So the implementation process was first to take an idea what we are doing. Then we did medical analysis and defined the dispatch parameters. Then we had to do a lot in the dispatch center for technical implementation, the whole process. Once this was all safe, we had to kindly ask the politicians if they would go with us. We had a medical proof, but the politicians have to decide if it works. And then the main task, and that's what the main topic I'm talking is that we had to start a communication process, internal and external, before we went live. So what we did first, this is our data analysis of all medical cores. Here we have a near unconsciousness situation. So we are looking in the medical calls from the run reports, how many patients need to be resuscitated, how many patients needed advanced care, and other things. And we decided for each code which response would be appropriate in terms of medical teams, ALS, BLS, or the time frame we send units. So the old system, as I told you, there was BLS with an EMT, ALS either with a paramedic, or as in Germany always, we also have EMS physicians. And the new system now decides between urgency and the qualification and has different time frames. Our goal is to reach the most important patients in 10 minutes. Those patients who are maybe have a life-threatening problem in 11, and all the others in either 16 or 22 minutes, and also to send patients which are not in the right system to a general practitioner service. So before the launch, we had forms of communication. We started with the press representatives because since the system is overstressed since a while, the press is very eager to know what's going on. I can remember times when we were in the local media each day, so we decided that we take them with us and inform them as soon as possible. We also informed the health administration, and internal we informed the staff. We had a frequently asked questions box, and we had informed all crew chiefs of the fire stations and the lead paramedics about the changes. We had, for the whole personnel of the Berlin Fire Department, we had a live stream recorded so that everyone had the chance to get informed. And we now still have an ongoing support with service mailbox and so on and so forth, and we update on every change we are doing. So the key learnings in this whole process was that it really helped to early inform the external, the press representatives. And since it's a very complex issue, it needed some time to explain all those things in detail, and to prevent the false information that we only do this not for medical need, but the system is overstressed. We definitely reached our goal to inform everyone that the changes we did are because of medical needs and to want to serve the public better than before, rather than some sort of changing names for the same things. The first line of management is the most important stakeholders, and station leaders and shift leaders need to understand the changes. So also this was a large things of information we had to do. So that's about it. And I'm really looking forward to any questions you have.
Andre, I will use my prerogative as moderator
Yeah.
to ask you, did you manage to convince? Because I think politicians will kill you. They would come at you saying you are downgrading the level of service that you're providing.
We were able to convince the politicians before. Otherwise, they had their thumbs up before. So we could convince them with the medical data I've shown you. We showed them for every possible medical situation that you could explain to a politician, very easy. So if your heart stops, we will be there in 10 minutes. If you have a bad ache, we will take 22 minutes. So and we show them the data. So they were convinced and allowed us to do the whole process. And luckily, we have a little more than one month now. It's stabilized the system, and we were able to keep our response times in the most urgent cases, and we are now really fine-tuning the system more and more.
Thank you very, very much. Are there any questions from the audience? If not, I would kindly ask our experts to stay and hand over to Michelle. Michelle.
I'm there, thank you. Internet was a little bit slow to load my camera. So again, thank you to the speakers. I think everybody could learn a lot during your presentations. And thank you to the attendees to have been here. And I'd like to promote our next webinar on the 29th of May. The topic will be psychosocial interventions in EMS. Stay tuned. You will receive a normal invitation to that, and follow us on LinkedIn. Then you won't miss any new topic as well. And I've just posted it in the chat. If you want to receive a certificate of attendance, just register under the link and the QR code, and we will only use your data for that, and it will be deleted afterwards. So thank you for having us, and I wish you a pleasant evening, and I'd ask our experts to please stay in the room.